Okay, we'll move on. Um, so we dealt with metabolic diseases of the bone. Now let's deal with actual problems with the bone itself. We'll talk about bone fractures. Um, Again, bones break due to trauma or physical forces. It's the most common bone lesion. Do you guys like this laser thing that goes away, or you want the real pen? No, real pen? Okay, I'll go back. If it works. Okay. I don't know. Yeah, well, the pen's not working now. I don't know why. I'll figure it out later. I don't know. I'll figure it out. Okay. The problem with fractures is not so much the bone fracture itself, it's the damage that it does to the surrounding tissues. So you get muscle necrosis, hemorrhage. Remember, bones have a ton of blood supply. If you break that bone, blood's going to leak out. Depending on how severe that bone break is, you get a hemorrhage going on. Tearing of tendons and ligaments, nerve damage from that stretch or tearing. So a lot of things are involved with when you fracture a bone. Keep this in mind. So when you guys are getting into your OSCEs now, talking about how to do a focused exam. If someone's coming in with leg pain and you think they have a fracture, what systems are involved that we're talking about here? What systems? Circulatory, we have a hemorrhage, right? What else? Nervous system, nerve damage, musculoskeletal. Those are the three systems in your leg. So if you're doing an ROS, make sure you hit those three systems because those are what's in the leg. If you're dealing with chest, lungs, cardiovascular, GI. If you're dealing with the head, if they're sick, anything in the head, throat, and even in the lungs. And abdomen if they have certain other diseases. But that's right. One of the ENT things, right? They have a sore throat and it causes a GI upset. Yeah. Is a mono thing? So keep those things in your mind when you're doing your OSCEs. What systems are in that area that I need to be worried about? So these are the different types of fractures. You got to know these ones. So we have a transverse, just goes right across. We have a spiral fracture, and it's just spirals, a twisting of the bone. Oblique fracture. A comminuted fracture has many different pieces, all little tiny little pieces from that fracture. That's called a comminuted fracture. We also have a segmental fracture, which is obviously has two different areas that broke. And the last is a compression fracture. Obviously, compression of the spine, either landing on your feet really hard. If you have underlying osteoporosis, those vertebral bodies get very weak and they can crack. So that's called a compression fracture right there. So those are different types of fractures. So you don't need to know this for my class. These are called Salter-Harris fractures. And when you get to ortho, you're going to have to know all five of these. But what I want to bring up to your attention is that gray line is what? Your epiphyseal plate. That's your growth plate. I kept saying you don't want to crack that growth plate. You're going to have problems. So if you look at D, E, F split apart, but D and E, you can see definitely that there's a crack in that epiphyseal plate. Obviously, those are worse than the first ones because they don't involve the epiphyseal plate. So you don't need to know this for your exam. You do need to know it in ortho when it's brought back up again. My purpose is to tell you, you have to be careful for that epiphyseal plate. And the more severe down the road with these Salter-Harris fractures are, the more involvement you get of that epiphyseal plate, causing growth problems later on. So other types of fractures, this is called an avulsion fracture. Basically, that ligament was so strong, it pulled the bone right off. That's called an avulsion fracture. You also have a green stick fracture. It's called the green stick because you ever take a piece of green branch that's very, very young and you try and bend it and crack it, it doesn't just crack nice and like down the middle, it bends. And then the weakest part is going to break off. And that is what you're seeing there. Very common in children with abuse. You'll see this. So if anyone come with a green stick fracture as a child, don't just assume they were abused, but in the back of your mind, look for signs of abuse that may be there. Stress fractures, again, increases in stress of areas in high activity. So you get tibial stress fracture, you can get stress fractures in your feet from repeated running. Here's a pathological fracture that happened in the humerus. Many years ago, there was a pitcher who had cancer in his arm. And he got treated and he was okay, but obviously the bone was weaker from the treatment. He went back to pitching, and pretty much the arm exploded inside the bone exploded inside his arm from the force of throwing it, just shattered the bone. So those are pathological fractures due to tumors or metabolic disorders. Not a normal fracture, it's a pathological one due to the underlying cancer that made that bone very weak and brittle. So what happens when you break a bone? First thing is the inflammatory phase. Okay, hemorrhage from that blood loss that occurred goes into the periosteum and those adjacent tissues, and you get a formation of a clot. We also get extensive bone necrosis because there's no more blood going to the part of the bone that broke off. So that part of the bone will start to necrose because there's no blood supply to it anymore. It gets weaker, necrosis off. The clot that formed up here must be resorbed for that fracture to heal. So what goes on? In early stages, we have what's called neovascularization. We have to create new blood vessels to attach back to the part that broke, so we have blood supply that can feed that bone and repair it. Remember, you need blood to repair things. We have woven bone is formed after 7 days, and that's called a scar. And then at this fracture site and within the bone marrow, you'll see these changes on the x-ray. We have pluripotent cells give rise to osteoblasts. Makes sense. We have broken bone. We have to repair it. Osteoblasts repair the bone. And they're going to get in and start repairing that damaged tissue. Cartilage is also formed. And later on, once the site has healed, we get formation of a callus, granulation. And I have a picture. This is a fracture repair. That is a callus. And on this side too. Those are callus formations from broken bones that were repaired. They found from ancient civilizations from 100,000 years ago. One of the ways they knew they were civilized civilizations is because the people's skeletons that they found had calluses on them, which means they were healed and they were treated and recovered, which is a sign of civilization, that you're able to treat other people and take care of them. So they find these callus formations. If you see callus formations on a chest x-ray, on the ribs, could also be a sign of abuse. I'm not saying it's 100%, but normally you don't, unless they have a car accident where they actually have a method of why they had broken ribs. If you see someone with calluses on the ribs, that means they had damage to the ribs and it healed up and repaired, but it could be a sign of abuse again. So next we have the reparative phases and we have the remodeling phases. Reparative phase, first week, can last weeks or several months. Cells differentiate, we get our osteoblasts forming. Repair proceeds from the periphery inwards, so it starts on the outside and works its way into the bone, into the medullary part of the bone. Okay, resorbs the clot, new vessels to that fracture site to promote healing. Then at the end, we have the remodeling phase. Takes several weeks post-fracture. That callus is formed that sealed the bones, and now we start to remodel. Bone is reorganized along its stress lines and mechanical forces, and the original cortex is back to being restored, and now your fracture is healed. That's why you get immobilized in a cast, so you don't move those bones so they can heal. It's called union. They can come back together in a safe way, and we're going to go through some problems with that in a second. So again, here we have our fracture. There's the hematoma forming from all those blood vessels that got destroyed and ripped. Blood's going to still pour into that area. Then we start getting new vessels starting to form to bring the two pieces of bone back together. Then we start from this side, and they work in to start healing from the outside and work its way in. We start getting this callus forming here. The little bumps right there. And then at the end, finally, we have our bone remodeling phase, and bone's nice and lined up again. Vessels are intact, and it's repairing all that bone. So that is what happens with our bones. Now, we have complications with fractures. A non-union is a fracture for a minimum of 9 months post-occurrence that's not healed and showed no attempts at getting close together. So you can see here, this non-union, those bones are not connected. So that is a non-union. They have not come together. The one next to it is a malunion, which just means that, yes, it did come back together, but it did it in a wrong way. And that bone is not stable, and that will break again. That's a malunion, where they did join, but it just didn't do it the right way. Non-union, they never came back. What are some causes? Soft tissue got into the site. Once soft tissue gets in that area, the bone won't fuse back together because tissue got in the way. That's one reason you can have a non-union or a malunion. Excessive motion, that's again why we cast you. We splint you so you don't move that joint so that the bones can stay in line and they can heal. Infection or poor blood supply. Again, you need blood to heal. Other complications, something called compartment syndrome. And this is a condition with increased pressure in a confined body space, usually the leg or the forearm. Meaning, if you break your forearm, you're going to have a lot of hemorrhage in that area. Your skin is going to stretch to accommodate the swelling that's going on. If there's too much blood going on, everything's being stretched, but the skin can't get any bigger because it's a skin, it's connective tissue, it's all one piece. So what happens is all this blood and pressure starts compressing all the structures in that area. And that's called compartment syndrome. All muscles and area blood supply are all in these compartments. They're separated by fascia. So fascia is that layer over all the muscles. Massage techniques are trying to make that fascia relax, and that allows your muscles to relax. When you feel like muscle knots in that's the fascia, what's going on. After you had an injury, blood or edema may accumulate in that compartment. Your fascia can expand, and you get compartment pressure. Okay. Prevents adequate blood flow to the tissues, causes severe tissue damage. Loss of function or death can occur. Again, most common in legs, arms, and abdomen. Abdomen can happen after motor vehicle accidents. They get crush injuries into the abdomen. Internal bleeding occurs. Abdomen gets big, but it can't get much bigger because the skin's there. Starts compressing tissue. So you can see here is the break. There's the vessel rupture. There's all the hemorrhaging going on. Again, there's nowhere for this stuff to go. It starts compressing your tissues and causing immense amount of pain. So etiology, bone fractures will do it. Your crush injuries, talking about motor vehicle accidents. Yes?
How do you identify
compartment syndrome?
Yeah.
Well, they're going to have a fracture. They're going to have a really severe pain in that area. Swelling. It's not going to look good. And we'll show you some pictures in a second. Burns are here. Overly tight bandaging can do it as well. Any athletic trainers here? Wrapping tapes? No one wants to say anything now if I'm calling you? Okay. Anyway, that's why you got to be careful when you wrap people's wrists with the tape, because if you do it too tight, you can cause a compartment syndrome. Prolonged compression of a limb during a period of unconsciousness can do it. So if you pass out or have a stroke and you're down on the ground and you can't get up, you're going to be down, stuck on the ground for a while. Surgery, blood clots, vigorous exercise especially eccentric movements. What are eccentric movements? Lowering. So this is concentric. This is eccentric. You get more muscle building with eccentric motion. It's just very dangerous to do. You can pop those things real fast. Again, extension under pressure. And anabolic steroids, muscle enlargements are very rapid and nothing can grow. The skin doesn't grow and you get compartment. Abdominal compartment syndrome is always after severe injury, during critical illnesses and so forth. Here's your trauma. Abdominal surgery, specifically liver transplants. There is a ton of blood in the liver. And when you have liver transplants, there's a lot of blood loss, blood oozing, and blood that can go into different areas of the abdomen, causing compartment burns, sepsis, severe ascites will do it, pelvic fractures. Again, you're bleeding and it can just pool up in the blood and pool up in the abdomen. Again, exercise can do it as well. As the pressure in that compartment rises, circulation to and from the liver, the bowels, and kidneys may be injured or permanently damaged as well. So these compartment syndromes are no joke. So there's two different types. There's acute and chronic. Acute is the medical emergency, severe injury, permanent muscle damage. The chronic ones, not a medical emergency, okay, most often caused by like athletic exertion. So you worked out too hard, swelling was great. Remember, when you're working out, you're ripping those muscles. It could cause little tiny bleeds, but if it's too much, you may get a little bit more. Signs and symptoms. New persistent deep ache. Pain out of proportion. Okay, what does that mean? It doesn't look bad. You're looking at someone, they look okay, but they're complaining of severe pain that doesn't look like they should be having that much pain. Compartment syndrome, you may not look like they have compartment syndrome, but if you're complaining of severe pain at some point, that's something you want to check out. Numbness, pins and needles. Why do they get that? Nerve compression. Remember, this is compartment syndrome. We're having increased pressure in that area. We're going to start compressing structures. That's why keep in mind, if it's in the leg, neurovascular, musculoskeletal, even skin, are all the systems in the leg. You want to explore all of those in your history and physical. Electric type pain, that's still that neural pain. Swelling, tightness, bruising, especially if you have a cast on. The treatment, remove the obstruction or do a fasciotomy. And this is what a fasciotomy looks like. They actually will cut the fascia, releasing the pressure, and the pain starts to go away and subside. But obviously you have to do pretty big incisions because you have to get that whole area out. Yes?
If it's chronic, is it usually bilateral or is it just one?
Usually one. Mm-hmm. So that is what compartment syndrome, that's the treatment. This person probably split on its own. This was an incision. You see the difference? They cut right here and the skin is, whew. You ever see those Japanese omelets where they just cut it and then, whew, hold on. That's what that is. It cuts it, it opens up. This is a cut. Nice and nice simple cut there, folds open. This probably happened to trauma. When I was a student, I had a patient that came in. She had chronic lymphedema in her legs, so both legs were chronically swollen and very, very tight with edema. She went to bed at night, and her husband had a dream and kicked her by accident, and her whole leg split all the way up the side. We couldn't get the sides to go back together because all the water that was just pouring out of the leg, it takes a while. So that stuff like this will be left open for a while. Not like months, but like it's going to be open like that, and you'll put like, I call it saran wrap essentially, plastic wrap over the whole thing to keep it sterile and clean while you recover. So these things stay open for a little bit. Moving on to osteonecrosis. This is also known as avascular necrosis or aseptic necrosis. Avascular necrosis, what is that referring to? Yes?
Oh, when the swelling goes down,
Yes. You put it back and then you suture it back up and you clean it back up again. Okay, avascular necrosis. No blood supply. Remember, what is one of the major processes that has to happen for our bones to repair itself? Neovascularization. We have to make the new vessel to get to that part that broke off. If that doesn't happen, you get what's called avascular necrosis. Usually happens right up here in the hip. Okay? Very, very famous football player, also played baseball, went to Auburn, broke his hip playing football because his hip socket got pulled out, developed avascular necrosis, had to get a hip replacement, and there was his football. He was done with football. Anyone know? Bo Jackson. Okay, that's what happened. That's what killed his football career. He tried doing baseball for a little bit afterwards, but avascular necrosis. He broke his hip. This part of the femoral head didn't have any blood supply, so that bone just died off. And there goes your hip when that happens. You need a whole new hip. So, etiology, trauma, emboli will do it again. If you get a clot that gets lodged in there, anything distal to that clot will not get any blood supply. Systemic diseases, polycythemia, here's your lupus again. It always pops up. Radiation, focal bone necrosis. You'll learn about Lebkap-Perthes in ortho in the winter. Thrombosis, a clot, or maybe just idiopathic. It just happens, we don't know why. So what happens is, because we don't have a really good blood supply, the healing goes what's called creeping substitution, whereby the necrotic marrow is replaced by invading or creeping neovascular tissue, and that helps provide the cells needed for repair. We have necrotic bony trabeculae are sandwiched between the new bone, and that causes it to be weak, and then they can crack after that with weight bearing because they were repaired in a very, very poor way. That bone is not structurally the same anymore, and it's going to break. So the repair process, we have to try and remove that necrotic bone and replace it with viable tissues. We have to do some removal. If the infarct is very small and there's not much weight bearing, then the process usually goes and we're okay. But it is unsuccessful in about 80% of patients, and the infarct gradually collapses and the bone breaks. At the end of the long bones, overlying articular surface become flattened and irregular, increased pain, and eventually osteoarthritis. The bones are getting weaker. Most common symptom is going to be pain. Some may not have any pain at all. Groin pain is very common when it's the femoral head. Think about it, the femoral head is inside the hip, so that pain is going to radiate into the groins. So they have that, maybe some thigh pain or buttock pain, because remember the fracture is happening in the femoral neck. Weight bearing is going to cause a lot of pain because every time you walk, that bone is being compressed and it causes pain. Rest pain occurs in about 2/3 of patient, night pain in about 1/3. And although rare, pain in multiple joints suggests a multifocal process, that usually it's going to be one joint. But if you're having multiple joints with this avascular necrosis, this osteonecrosis, something is going on. You could be hypercoagulable. Remember, one of the etiologies of this is clots, thrombi or emboli. If you're in a hypercoagulable state and you're developing these clots, they can get lodged in the right hip. They get lodged in the left shoulder. Then you start getting avascular necrosis of the shoulder, and that's how it spreads. So if you see it in multiple sites, something is going on behind the scenes. Okay, this is osteonecrosis of the jaw. So when you guys do your oral exams, this is the things that you're looking for. When you start raking the teeth, you're looking for sensitive teeth. This is bisphosphonate-related osteonecrosis of the jaw. Bisphosphonate is a drug. One of the side effects could be this. So if you start seeing this forming, stop the bisphosphonate. Okay. Osteomyelitis is an infection of the bone or the bone marrow. It's an infection, so we have some underlying etiologies. Staph is one of the big ones, E. coli, gonorrhea, influenza, and so forth. Difficult to treat due to bone anatomy. We have to try and get those antibiotics there. It's tough. So what is going on? We have, in stage 1, we have this infecting organism that gets into the medullary canal of the bone. Okay? So it gets, these bacteria get inside into the canal in the bone. Then we have an infection there, and pus is going to start going there and forming. White blood cells will get to the area to try and clean out the antigens that got their way into the medullary part of the bone. That pus that builds up starts building up pressure. It's got to find a way to get out and break free. So what happens is we get what's called a sequestrum, where this whole thing gets sequestered. We get new bone forming here. And I have another picture that kind of goes a little more detail. You get other things in there called an involucrum, which is like the free bone that's kind of floating, and I have a better picture for that. We'll get there in a second. It's right there. Okay, we'll get to it. Okay, so there's 2 types of osteomyelitis: exogenous, outside the body, open fractures, penetrating wounds, surgery. Most common cause in the United States is staph, strep, these anaerobic things. The endogenous, this is coming from somewhere else in the body that there's a source of the bacteria somewhere in the body, but that bacteria got into the bone and caused an infection in the bone. But you got to find out where the first cause was. Where's the source of this infection? Sites most commonly infected with the endogenous, the long bones, knee, ankle, and hip. So again, here is the bacteria. There's the pus developing. We get a little canal forming so they can get out. What happens, it lifts the periosteum off because of the pus that's in the area. It lifts the periosteum off. And that's where we have to start repairing things, because that periosteum is lifted off. We have to take care of it. This is osteomyelitis, again, of the mouth. Sources of infection, cutaneous, and so on and so forth. Bacterial contamination, soft tissue disorders, GI, respiratory infections. Remember, these are all ways to get into the body from outside sources. And remember we said, what's the most common cause? Exogenous, coming from the outside in. And look at these ways to get in. Soft tissue, GI, GU, respiratory. That's how you can get into the body from outside. This becomes a problem. Total joint replacements. When we replace your joint, we're putting in a foreign substance. It's metal. It's very, very slick, so we hope bacteria don't attach to it. That's why it's so slippery. Sometimes it does. So if you have a patient coming in with signs of osteomyelitis, and they had a hip put in 3 weeks ago, a month ago, 2 months ago, guess what's coming out? The entire hip replacement. They have to take it all out because it could be a source of that bacteria. You don't know where it is. That's what I'm saying. You have to find it. And if they have a joint replacement, if they have a pacemaker put in, and they have wires that go into the heart, those can get infected as well. Bacteria can attach to the lead, that wire, and it starts to grow. We don't know that. So guess what? All those wires have to be taken out of the body, let your body heal, infection goes away, then we put it back in. So hip replacement, knee replacement, they all have to come out. Wait until they're clear of the infection, and then we can put it back in. So, question? Yeah.
What would you do in the interim when you're taking out like a hip replacement?
You plastic wrap it up and don't move until you're clear. You're bedridden. If it's a hip or a knee, you can't walk.
You just don't have a hip?
You don't have a hip? They take it. Yeah, they have to wait for the infection to clear and then they put it back in. But you have to wait for the infection to go away and then they put it back in. Yes, you'll just kind of just wait and hang out until it clears, then you go. So what happens here? Inflammation. Vascular engorgement, edema, abscess formation starts to happen. Okay, inflammation causes thrombosis and seals that channel to sequester that bacteria. We don't want it getting out. It got its way in, let's sequester it, leave it there, and we can take care of it. Inflammatory exudates. Okay, it's an exudate. What does that mean? High in what? Protein. And usually due to what? A malignant source, right? Exudates are usually not good. Transudates, heart failure, edema, and so forth. So necrosis and death of that area of the bone affected produces a sequestrum. And we're sequestering that devitalized bone. If that bone broke off and of the periosteum as it lifted off, you have little bone fragments. You can't take those bone fragments and put them back in the bone. They have to be taken away. So we have a sequestrum to do all that. Then we get intense osteoblastic response. We're going to build more bone, new bone around the infected area, and that's called an involucrum. Involucrum is new bone coming into the area around the infected bone. That's called an involucrum. Unfortunately, we have little openings in this involucrum. What that allows is for these exudates to leave the bone and start penetrating the surrounding tissues. And when that happens, now you have a bone infection that caused a soft tissue infection. Okay, and I'll have some, and again, here's just the phase that we talked about. Here is that involucrum. Okay, all these little pieces of bone that are just floating around, we want to get rid of them. Again, they're trapped. That's that sequestrum. So they can't go anywhere, but we have to get rid of them as well. Physical exam findings for osteomyelitis. They're going to have signs of inflammation. Redness, swelling, heat, temperature, loss of function, decreased range of motion, makes sense. Drainage, sinus tracts, and ulcerations. It is a horrible smell. If anyone worked in the ER as a scribe and you saw a patient with osteomyelitis, it smells very, very, very bad. So if you see a skin infection and it reeks and it looks very, very red and inflamed and all that stuff, think osteomyelitis. Complications, obviously, they become septic, all this bacteria is floating around. Acute bacterial arthritis can happen. Pathologic fractures, we talked about that before. The bone's getting weaker from the necrosis that's going on, and it will break. Small musculoskeletal carcinoma and chronic osteomyelitis. Last section is on osteoporosis. Obviously, decreased bone mineralization, loss of bone mass, that you can no longer provide mechanical support. That's the main goal of the skeletal system, is support of your body, and when that fails, you're going to have issues. Hallmarks, bone loss, obviously bone fractures. This is where you get your vertebral compression fractures. Okay? Hip fracture is very common, and a Colles fracture is a forearm fracture. Why do they break their forearms? From the fall. Okay, they break their hip or they trip over something, they fall on an outstretched hand, and that breaks their forearm. Again, it's a weak bone. If they were working on and exercising, they had strong bones and they fell, they would be able to support themselves and not break their bone. But they're osteoporotic, and that happens. Etiologies for osteoporosis, here's your smoking, vitamin D deficiency, we know why. Low body mass index. So we talked about Wolff's Law before, that the compression of the bones makes them go stronger, that you use them. When elderly people get very light and they lose all that weight-bearing part gets weaker and weaker, so those bones don't have the stress anymore. So when they're like 75 and 80, don't worry about their weight. Let them be overweight. Let them eat whatever they want. Like, they need that mass if they fall and they hurt themselves. These frail old ladies, they fall, it's like they turn to dust. It's like powder. Okay? Get them working, they'll be fine. Hypogonadism, why? Estrogen. Talked about estrogen in the very, very beginning and how it helps with bone mass. Sedentary lifestyle. You're not compressing the bone with mechanical forces through activity, because you're sedentary all the time, they're going to get weaker as well. Glucocorticoid therapy. That's what we talked about before with the rheumatoid arthritis. They go on hydrocortisone, cortisol, your glucocorticoids. It can also cause osteoporosis and your alcoholism. So osteoporosis peaks, bone mass will peak in your 25 to 35-year-old range and begins to decline in the 5th or 6th decade. Increased incidence in osteoporosis in whites and Asians. Hip fracture, the greatest morbidity and mortality and direct medical costs. Why? Why do you think that is? Sedentary. What else has to happen? If you break your hip, you go for surgery. What happens? One, you're in the hospital. You get sick. Before even that happens, what happens if you're stuck in an immobile position for a long period of time? Clots. Now you have that to worry about, right? Now, you had hip surgery. You can't just go home. You got to go to rehab. That adds cost. Now you go home. You have stairs in your house, and your bed's on the 2nd floor. You can't go on the stairs anymore. Now you got to move your bed to the 1st floor so you can live there. You see, like that's where this costs start building up. Not the hip fracture, you treat that and you're fine, but it's everything that happens after that. All adds up, a lot of money. Frequent places of fracture for osteoporosis. The biggest one is this femoral neck fracture. You also get intratrochanter fracture and fracture below the trochanters, but the femoral neck one is the most common one they're going to have. So what's going on with osteoporosis? We know we have bone formation and we have bone resorption. As long as both sides are equal, your bone mass stays constant. But if the osteoblast activity reduces or the osteoclast activity increases, you're going to lose bone density. And that's what's going on. So osteoblasts and clasts belong to this thing called a basic remodeling unit of bone. Those less than 40 will replace all your bone resorbed during that remodeling process. So long as you're under 40, metabolically active bone, everything that gets taken away, you replace very easily. With age, less bone is replaced than normal. Over time, these small deficits start to add up, and you get severe loss of bone mineral density. So again, oversupply, overactive osteoclasts, or undersupply, underactive osteoblasts. If they're equal, bone mass stays the same. When they're not, you get changes. So senile osteoporosis, what does senile mean? Old. Okay? With senile osteoporosis, they get reduced trabecular thickness. Postmenopausal osteoporosis shows disrupted connections between the trabeculae. So that's the difference between the osteoporosis and how they develop. And again, you lose your trabecular connectivity, you decrease the biomechanical strength, and they can fracture easier. Two types of osteoporosis. Primary origin is uncertain, but is the most common one. We don't know why they have osteoporosis. There's no underlying cause. It could just be due to age and so forth. Again, primarily postmenopausal women, and the type 2 is both sexes, but it's going to be the elderly version. So type 1, increase in osteoclast activity. Okay, and this is why. Estrogen withdrawal causes the increase in osteoclasts due to the secretion of cytokines that recruit osteoclasts. That is why type 1 has to do with postmenopausal women. Type 2 is just your senile osteoporosis due to age. After age 70, and reflects decreased osteoblast function. As we get older, the cells just don't work as well as they used to, so we have decreased osteoblast, so the osteoclast wins out, and you lose bone. The secondary one is has a definite cause. Usually endocrine or genetic. We've already gone through some endocrine. Remember also, here's your corticosteroid use. People with rheumatoid arthritis, other conditions that need steroids. Here's your hyperparathyroidism, hyperthyroid, so on and so forth. So anything dealing with calcium metabolism causes issues here. Etiology, genetics is the big one. So always ask about family history. Ask about their calcium intake, vitamin D. Are they getting out in the sun? That's how we can get it for free. Environmental factors. Are they smoking? Do they need to stop smoking? Find out what's going on. And exercise. They got to maintain that bone mass. Okay. So here's a good summary slide as far as the different things that will cause you to have osteoporosis. Here's your forearm fracture, again, when they fall. Postmenopausal osteoporosis usually happens 10 years after menopause. Senile is after 70. So again, ask your patients when, if it's a female, you always ask about when was your last menstrual period, and it said I'm stopped. Find out how long ago have you been menopausal. 5 years, 10 years, or whatever. Signs and symptoms, usually going to be asymptomatic. They're going to have vertebral body compressions because they got weak. And you can see there, that vertebral body, it looks good here. And then there you have all the mess up stuff. That'll go away. And that is your compression fracture due to osteoporosis. They'll just present to the ER with back pain and they do an x-ray. Like, oh, you got compression fractures. Why? And you start digging. Oh, you got very weak bone mineral density. What's going on? Signs and symptoms, kyphosis, a Dowager's hump. Because they have lost structural integrity of the spine, they start hunching over. And loss of height. So again, with osteoporosis, you start shrinking. So height changes over time due to the compression of the vertebral column due to the weakened bones. And this is what a Dowager's hump is. And again, your risk factors, your summary slide. And we're done with ortho. Okay, EKG people are already here, so take 10 minutes and they'll start early. You guys get out early. Okay, have a great weekend. Good luck on farm on Monday.